Hello everyone, good afternoon. My name is Dr. Laz Ude Eze. I'm a public health physician and sustainable development consultant. I'm also an entrepreneur and also active in promoting youth development, leadership, good governance at various levels. So been active in the political space, essentially for the purpose of ensuring that we get the right leaders into various positions, because I understand and I'm also of the belief that a lot of things depends on leadership. And with the appropriate leadership development, we move faster. Today, 15th June 2025, is a Sunday, and I started this broadcast 1 p.m. I had made this announcement much earlier that I will make a broadcast today, and a lot of people excitedly were asking what is it about, and excitedly want to be part of it. And I really appreciate everyone that made out time to be a part of this. I can imagine what could be going through some people's mind. What the heck does Laz want to talk about? Is it about politics? A lot of comments that came under that my post was making suggestion around that. Is it about personal life? Is it about, what could that be? Is it one of those who want to defect from one party to another? Since this appears to be a season of transfers, not any of that. On this day, on the 15th June 2020, 5 years ago, I convened a number of Nigerians, especially between my birthday, April 2020, and that June. We gathered for humanity. We came together, as at that time there was COVID-19 lockdown. There was a lot of confusion across the globe, and people were like, can our health sector survive? Can we carry what is happening? Anyway, I think there's periodic slow connections, bear with me, not entirely within my control. So, and on 15 June, we made a huge statement in 2020. And that statement was in keeping with the birthday wish I made that same year. On my birthday, I made a post that my birthday wish is for us to join hands and make our hospital work. And it got people talking. It got a lot of persons interested. So that conversation led to a formal launch on 15 June 2020 of the Make Our Hospital Work campaign. A lot of persons played critical roles in making that day happen. And too many persons, I may not begin to mention individuals now. There were like 300 and over 350 people who had signed up as at the day of our launch. And as I speak, we have over 1,000 people who are signed up. And when you include those who are in various communities that are part of the campaign, we number over 2,000 people who are part of the campaign. So, over the past 5 years, a lot has been done in the Make Our Hospital Work campaign by different people in their communities, because it says it's a citizen-led, community-based advocacy. So I'm not here to talk about those things that have been done. Quite impressive. I've talked about some of them in my radio shows and TV shows, different posts online. So today I want to make a clarion call as a citizen, something that bothered my mind over time. if you may have noticed, see that I've kind of lost some enthusiasm in the way I push certain stuff. Not because I don't believe in them anymore, but because it appears like the more we are pushing, the worse things we are becoming, especially in the health sector. It appears that people, don't really care when they are not personally involved. So while I and a number of other persons tend to push for things to be in a situation where many of us, will not fall victims of our health system, some feel that, it's their job, they are doctors, they are physicians. But I want to make a passionate appeal that is about humanity. It's about all of us. One of the reasons I do what I do, is for personal reasons. That personal reason is because I see myself as a potential victim, as someone who could require this support. I'm not seeing myself that, as a doctor, maybe when I'm ill, I know a lot of colleagues. If I go to the hospital, I'll probably get speedy attention and preferential treatment. But that's in a very regular situation. But I could be traveling. I could be in my hometown. I could be in someone else's hometown for a visit, or even for work. I travel to a lot of states across the country to work, both rural, urban, hard to reach communities, to do some work. And I may have health needs, and it could be a health emergency actually. So what if that comes up? And in the situation of emergency, the message is go to the nearest health facility. So what if that nearest health facility can't save me, even in a situation that ordinarily I could be saved? So that's my thoughts, that, I want the hospitals or health facilities to work because I could be the potential beneficiary. It could be my loved one, it could be my child, it could be my friend, it could be someone I respect, it could just be anyone. Before I proceed, today, before this video, I was somewhat moody because I received news that there's an explosion in Borno State that took the life of 2 health workers. One is a world focal person, the other one is a community leader. Some days ago, I think especially yesterday, the National Immunization Plus Days commenced in a number of states, especially in the northern parts of Nigeria. And house-to-house immunization is a strategy that is being used in Nigeria to reach communities or locations where people live far away from health facilities, and also where people, for one reason or the other, might be rejecting immunization. So the communities are involved so as to educate them and encourage them to take vaccines. Given that if you wait for everybody to go to health center, maybe that might not be feasible. And the government really wants every eligible child to be immunized, especially those who are below the age of 5. So these health workers are involved in activity, and on their way to the settlements where they will do this, 2 of them lost their lives this morning. My heart goes out to their families, their loved ones, and also the health team, the immunization team in Borno State, the State Ministry of Health, and indeed the health community in Nigeria. These women, men, and people who are involved in immunization activities across the country are heroes. Sometimes I feel they don't get the recognition they deserve. And of course, for health work, will never be paid enough. how much do you really earn for one life saved? So I condole with the families, and I condole with all health workers or the health community in Nigeria for those lives we lost this morning to explosion in Borno State while they were involved in immunization activity. My heart also goes out to the victims of the senseless killings in Benue State. News reports showed like over 200 people. This mindless, and I don't really know how to talk about this. It's very mind-boggling. It's very disappointing that we continue to lose lives of Nigerians in very avoidable situations. And not just in Benue, across the country where we experience this senseless loss of lives from preventable situations. My heart goes out to the families and loved ones of the victims. So coming back to what we're talking about, I thank everyone that have joined. The law, I can see you. You've been troubling me. Noble, happy birthday, Noble. Dab, Christian Emezie, Dabrechi, Barrister Guato, Dr. Gideon Okorie, and so many of you. Thanks for joining. So I'm making an appeal. I'm not making a political announcement like some of you were expecting, especially the law. I'm a youth leader, national youth leader. So I'm not announcing a defection to any political party. Speaking as a citizen, and I want everyone who is a citizen of Nigeria, especially those who are residents in Nigeria, to be concerned about this. How to make our hospital work. It's not just a slogan. It's not just a wish. If there's any time that we should take this more seriously, I think that time is now. And I choose today to make this speech and put it on video because I don't know how many pages I will write to fully convey my thoughts. And taking advantage of Facebook to make this video. So, the health sector in Nigeria is in big trouble. It has always been, but it's in a worse trouble at the moment. And many of us appear not to be seeing it. And of course, you will not see it until you have cause to go to seek health care, especially in locations outside the cities, where you don't have so many options. Before I go deeper to, give us insights on what this challenge is about, I want to describe what the normal is because a lot of time, many of us have not experienced a working health sector or a working health system. So we don't really know what the normal should be or what our policy says it should be. So I'll try to describe that in the simplest possible form. I'm not going to go very technical as much as possible. So we have the National Health Act, which is a law, a policy document that defines the health system in Nigeria. The National Health Act was enacted in 2014 after 10 years of advocacy. I was privileged to be one of those who pushed that advocacy, and I got involved around 2009, 2010, So it described what the health system should be. And the health system, just imagine the health sector as a house, or the health system as a house, right? Okay. Should I say a house? What's the best description? The system, you have the federal, you have the state, you have the local government, the three tiers of government, federal, state, and local government, right? So each of them, the federal, you have the Federal Ministry of Health, which is responsible for policy, development, and also managing the federal teaching hospitals and federal medical centers, and largely responsible for tertiary care, that's highly specialized form of care. Then the state government have the State Ministry of Health. The State Ministry of Health also has policy responsibilities at the state level. What's the difference? The country, the federal is national. At the states, there are some things that may be more relevant in Ebonyi than that may not be so relevant to someone in Edo or Sokoto, right? Certain things might be more relevant to someone in Ekiti State and not so relevant to someone in Rivers or Kebbi. So at the state level, you now leverage the federal policy and now do a policy that will guide you in the state that is most relevant to you and your people. Then the local government is also involved. You have the local health authorities. In some states, they have different names for it. You have the director of primary health care. In some places, it's administrative secretary of health department. So whatever nomenclature it is, but there's a local health authority and you have a head of that. Then, as also part of our health system, as explained by the National Health Act, is the community health committees. And this is an aspect that a lot of people don't know about, and a lot of people tend to underestimate the importance. At the community, you're supposed to have health committees, every community. What makes up a community might differ depending on the state, depending on the country, depending on the state, the region, the location, and all of that. For example, in the northern part of the country, you have districts, you have the emirates, so you have different leadership. The emir, you have the mengwas, you have different people. In the western part of the country, you have the obas, you have the first class traditional rulers. You also have smaller ones, the ballets as well, in some locations. Then in the east, the communities are a bit more smaller. You have the autonomous communities, which they keep creating in different states. In the Niger Delta parts, you also have different structures depending on the ethnic groups, the tribe, the states, different dynamics. But whichever level you define community, and you have a governance structure in that place, there is supposed to be a health committee. So whether at the level of emir or the sultanate or the igwe in council, the oba, the tortif, every level where you have a chief, every level where you have a chairman, you have anything leadership, there should be a health committee. That's what the National Health Act 2014 says in Section 2 of that act. So even up to the village level, there should be village health committee So according to the National Health Act, the health system includes the Federal Ministry of Health, State Ministry of Health, Local Government Health Authority, Community Health Committees, Village Health Committees. Sometimes they are called, before you even go to the village and community, there is the ward level. So ward health committees or ward development committees, community health or community development committees, village health committees or village development committees. You also have the patent medicine vendors, PMVs, that's the ones we call chemists that sell drugs. They are part of our health system. You have the traditional medicine, you have the alternative medicine, So they are all part of our health system. Then each of them have their responsibilities. That goes from the policy making, but I will speak more on the responsibilities from the state level down. Many times when we talk of health or many things related to governance, we point fingers up. We start calling the Minister of Health. Between the Minister of Health and the Commissioner for Health, the person that have more responsibilities to health as it affects you and I is the Commissioner for Health. Yes, between the President of Nigeria and the Governor of a state, the person whose functions will be more impactful on our health in the administration of our health system is the Governor. Why do I say so? The federal government, let me take a state for example. Let me take my state, Ebonyi, right? The hospitals that the federal government, of all the health facilities in Ebonyi State, the ones that are directly under the federal government is how many? Unless Ekpeme Federal University Teaching Hospital, Abakaliki. David Umahi Federal University Teaching Hospital, Uburu. Which other one? I learned at some point they are building a military hospital in Abakaliki. So if that has been completed, that will be under federal government, right? So of all the health facilities, then the Norfolk National Obstetric Fistula Center, right? Norfolk. So on the whole, just about 3 or 4 that the Federal Ministry of Health has direct control over. But the rest, whether it's a general hospital, whether it's primary health care, whether it's private hospital, are under the ownership or supervision of the state. The private hospitals get license to operate from the state government, even though the state don't own it, but they supervise them, they give them license to operate. So if they are doing the wrong thing, it's the state that has the power to say, oh, this hospital is doing malpractice, correct it, or we shut down the hospital. So what happens in the private hospitals is also under the supervision of the states. Every state, the Ministry of Health has the Department of Medical Services, Department of Pharmaceutical Services, Department of Public Health. There are various departments, and they all have functions. The public health gets involved in disease prevention, control of disease outbreaks and immunization and all of that. And Department of Medical Services, or even hospital services, there's also Hospital Management Board, which is like an agency within the State Ministry of Health. There's also the Primary Healthcare Development Agency, which brings all together all primary healthcare facilities in the state under one roof, under one umbrella. So it's executive secretary appointed by the governor. Before the primary healthcare agencies got established, every primary healthcare used to be 100% under local governments. But different local governments were managing them differently. There was a lot of confusion. So the idea of putting them under one roof came, pushed at the federal level, and I also happened to be one of those that pushed for that. And within the past 10 years, all the states, I recall around 2016, it was just about few states that had their primary healthcare agency fully recognized by law. And there was a scorecard that was produced by the National Primary Healthcare Agency with some partners that kind of did an assessment. But right now, every state has a primary healthcare development agency or a primary healthcare board. Okay? So that essentially puts primary healthcare under the states and under the governor. Hospital Management Board manages the general hospitals, which is secondary health facilities, right? And they're also under the states. The hospital services and all of that. So as you can see, whether it's private or public, whether it's primary or secondary, the federal government, the state government, the Commissioner for Health, the Executive Secretary, Primary Healthcare Agency, the directors in the State Ministry of Health, they are the ones that have more roles and responsibility to ensure that our hospitals are working and working well. Those that are government owned, they have the responsibility to provide all they need to work. And I will go into the building blocks of the health system where you understand better how the health sector works, what makes it work, why it is not working, and perhaps areas you and I could come in to make sure that it's working. I welcome everyone that just joined. Ron Sichidebe, I can see you. He was one of the founding members of the MakeOurHospitalWork campaign. My brother Chris, Kaji Sly, Ike, I see all of you guys. So thanks for joining this. So I'm just making a citizen's appeal, drawing attention to a very dire situation. I've not even described the dire situation where we are. When I get to that, I will use certain numbers, because if things keep going the way it is going in Nigeria, if you want to do, you might get to a point that you want to do surgery for appendix, which is usually a health emergency, or even hernia, you might have to wait for days, or you may have to travel out of the country to get someone who will be able to do it. It sounds scary, but we may eventually get there if we don't get involved and see things, because there's already a lot. If you've gone to any hospital recently or seeking health care and see how chaotic things are, it's worse than it used to be, So, in summary, in terms of government responsibility and who to hold responsible, the governors are to be held responsible more than anyone else, because the levels of care, we have primary health care, we have secondary, we have tertiary. Primary health care is the preventive one, is also the one that takes care of, you have malaria that is not complicated, you have cough and catarrh, you have headache, you have diarrhea, you have, majority of the health conditions that makes us uncomfortable can effectively be managed. Over 80% of our illnesses and things that, health needs, we need. Even oral care, scaling and polishing, all those things are primary health care. And primary health care, I will come a bit to that, is not just the buildings, the PAC buildings that we have all over the country. Primary health care is not exactly the same as primary health care center. Okay, a lot of people tend to confuse this. So PAC is primary health care, right? Then you also have primary health care facility. Some people use PAC to mean primary health care center. Some people use it to mean primary health care, whichever way. But primary health care PAC facility is the building, the facility where the care is given. But primary health care is a care that is provided, could be in the facility at the primary health center or primary health facility, and it could also be in the community. It could be in your home, so it could be it could be at the village square, where people are caught and sensitized on how to treat their water or how to prevent diseases or what to do when they feel ill. So that's part of primary health care. So primary health care is a huge component that emphasizes so much on prevention. It doesn't want you to get sick in the first place. So it wants your environment to be clean, water and sanitation, hand washing, it wants immunization so that children as well as adults don't get certain preventable diseases. And in elderly care, there are some people who are too old to start going to health centers. Primary health care has package for them. You can go to their homes and check their BP and provide care and support. And that's why within the primary health system, we have those who are different categories of health workers. You have the nurse midwife, who are usually quite the more popular ones. But we also have the community health officers. You have the community health extension workers. You have the junior community health extension workers. Many of the people you see in these primary health facilities that you call nurse, many times when you see a woman wearing white in the house, you call them nurse. If it's a man, you call them doctor. So many of them are not nurses, many of them are not midwives, especially at the PAC level. Majority are actually community health extension workers. In Ebonyi State, for example, I don't think you have up to 20 nurses in our primary health system. It's been a while nurses were hired, but some doctors were hired recently in the general hospitals, about over 30 of them, pharmacists and med lab scientists, and I think it was a good one because it's the first time such number will be higher since the creation of the state in 1996. So I keep referencing Ebonyi, not because I don't know what's happening in other states, but using that as a case study so that some persons might not get offended that I'm exposing some things that are not so good in their states. I actually know a lot about the other states' health sectors and things that are happening, let me use my state more. Nobody will accuse me. I'm a citizen and I can share my view about the state. But in every state, There are things that are working and there are things that are not working. So primary healthcare is that way. If our primary healthcare is working to its capacity, over 80% of our health needs will be met, including health education. When people have knowledge, they know what to do. Lack of knowledge can lead to sickness, illness. So every primary health facility by our national health policy is supposed to have not less than 35 staff, full-fledged. There are 3 categories of primary health facilities. Let me quickly go into that. There is a health post, there's a health clinic, and there's a PHC. The primary health post is a smaller one. You can use 1 or 2 rooms, and you can have like just 2 healthcare providers, and maybe a maximum of 3 or 4 staff. Okay, so it's just a small space. It does not operate 24 hours. It can operate maybe 8 hours or less, depending on the needs of the community. So it's very small. And you have the health clinic. The health clinic, you can use up to 3-4 rooms, and it could have up to 10 staff. Okay, it might operate up to like 12 hours or up to 15 hours, as the case may be, depending on the needs of the community. So it doesn't operate 24 hours. So it might just operate during the day and close at night. Health post might just operate in the morning up to early afternoon and they close. But the PHC, or the primary healthcare facility, is the one that operates 24 hours. It's bigger, and it must have a residential building for health workers. The full staff that needs to be hired according to the World Health Systems policy of the National Primary Healthcare Development Agency is 26 people. That will include nurses, community health officers, community health extension workers, and junior community health extension workers. And because are also laboratory technicians, pharmacy technicians, accountants, security men, and so on, including cleaners. So full category of persons. And because it runs 24 hours, it's not realistic to expect that people will be working 24 hours. So they run shifts. You should have those who work in the morning, those who work more at night. So perhaps those who work more at night will be those who are living inside the health facilities, and major deliveries many of the times tend to happen at night. Women in labor, you may also have snake bites, you may also have any kind of emergency at night that happens. So when you rush to a primary health care center at night, you should meet somebody, they are living there, right? So there must be accommodation in a primary health center. So any primary health facility that does not have a place for health workers to live shouldn't be referred as a PHC. Maybe it's a health post or a health clinic. They are primary health facilities, but they are not the full-fledged primary health center. So there should be one of those full-fledged primary health center per ward, minimum. Every ward should have a minimum of 1, but they can have as many, depending on the population. It's expected that if the population of the area is 500 to 2,000 people, you could have a health post. If it's up to 5,000 people, you could have a health clinic. Then for 10,000 population, you have a PHC. So within a location, you could have multiple health posts, multiple health clinics, and maybe 1 PHC serving a 10,000 population. So it's not just that if you have 10,000 people, you just have one full primary health center and you will not have the other smaller ones. No, those smaller ones are needed. For population of every 500 to 2,000 persons, you should have at least 1 health post. So where people could go and have basic, especially immunization in the morning and some of those activities. But they can also refer people to the PHC. So if, for example, you took a child who is having diarrhea, who needs to be on drip, maybe from morning till evening for resuscitation, the health posts most times just have 1 bed, and that bed is not for you to stay. You stay, you are examined, they do a quick resuscitation and you go. So if they do that quick resuscitation, maybe a child is brought in and is so weak have lost so much maybe blood or fluid, and they need to quickly put drip to resuscitate the child. They can do that within 30 minutes and call the primary health center, where the child can now go, maybe spend hours or even sleep over for one day and gets discharged the next day. So each of these health facilities supposed to have relationship, communicating with each other, so that this one, any case that comes and they can't handle it, they're already connecting with the other ones, and the patient is moved with an ambulance, right? I grew up knowing an ambulance as something they used to carry dead people. It only took me to be in med school to realize that an ambulance is meant to carry living people to save their lives. So, but in this part of the world, when we hear rain, is La Nudo and all those kind of songs that do come to our mind. But ambulances are meant to respond to emergencies and also in moving people properly from one health facility to another when a referral is made. So we are supposed to have this everywhere, okay? So it's a system on its own managing those things. And communication for referrals, this is what the design is meant to be, So as we are discussing this, you'll be asking yourself, in my community, which one? Because of anything politicians build, they give it a big name, So if they build 2 rooms, they call it a primary health center, PHC, but it doesn't really make it a PHC. It can be a primary health facility, but not a primary health center. There's a difference between primary health care facility and a primary health care center. Okay, so a primary health care facility is a general name for all facilities that you provide primary health services, which can be a health post, a health clinic, or a primary health care center. Primary health care center is the one that takes care of a population of 10,000 people. It operates for 24 hours. It has a residential building for people who are working there. Maybe not all of them, but at least those who will provide essential services, especially at night, live inside the health facility. Okay, so that's the design. I'm spending a lot of time in primary health care because it's the backbone of the health system in any country. Any country where the health sector is working is because the primary health care system is working. So primary health care system has different functions, different components, and it includes what happens in our home, in our communities. You may call people to the town hall, invite healthcare workers to come and sensitize them. The health committees in every community is also made up of the officer in charge of the health centers or the primary health care facilities. So the village health committees, every village should have a health committee. Then if you have a committee that is made up of different villages, at the community health committee, you have the chair, the leadership of the village health committees. They are all automatic members of the community health committee. Okay. At the ward level, you have the heads of the different communities health committees, also members of the ward health committee. And there's something that the National Health Act also did in section 11. It created the Basic Healthcare Provision Fund. So it's a money not less than 1% of the consolidated revenue of the federal government that should be going to primary health care. Okay? So, and this money is not only from federal, the state is expected to put 25% counterpart funding. Local government is also expected to put 25%. Development partners, even you and I, some of you watching, can donate money into that fund. So, and this money, the federal government working with the states, you have different gateways. 50% of that money goes into health insurance. And that's the reason why many states set up a health insurance agency. Because if you don't have a health insurance agency, you can't get that money. Because that money is there, they've all set up health insurance agency. So some states, in addition to that basic health care fund, are also funding health insurance agency. Some states only rely on this basic health care fund to fund their health insurance agency. And some of them are even demanding part of this money that should be used for health insurance for the citizens, demanding part of those money for I won't say it, you already know. So then 45% of this money goes to the primary healthcare development agencies. And out of this 45%, 20% is for vaccines, essential medicines. It goes into supporting movements around vaccination activities. It's not enough to buy vaccines. Federal governments of Nigeria and some international development partners are the ones that pull monies together to buy vaccines for the country. When it comes to the country, they distribute it to the states. Then the states provide counterpart funding, ensuring that the vaccines move from one point to another. So about 20% of the basic healthcare provision fund, is for essential medicines and vaccines and that. 15% is for health facility maintenance. Things that you may have challenges in the health center, a leaking roof, maybe they don't have water, infrastructure, all those things, just for those maintenance, it goes into that. 10% is human resource for health, training of healthcare providers, hiring of additional health workers where you need them. So each things that have to do with health workforce is 10%. So 10 plus 15 plus 20, that's 45. Then plus 50, that goes to National Health Insurance Agency, Authority, which also goes to the state health insurance agencies, is 50%. So it's now remaining 5%. 5% by National Health Act is for emergencies. Section 20 of the National Health Act says that on no condition should a healthcare provider reject or refuse to provide health services to anybody in emergency situation. Which means if you rush a patient to any hospital, is by law, it's mandatory that the people there must provide care in emergency situations. And there are situations that are considered an emergency, not when somebody is sick, you go and keep the person doing self-medication, or one miracle center, they are doing prayer. When the person wants to die or is already in coma, you rush them and expect miracle from the health workers. That's not the kind of emergency that is being described here. But in accident situations, or somebody slumped, or someone is bleeding actively, or even a woman who is bleeding from the private parts, is considered a health emergency. So in that situation, the healthcare provider must provide care, or at least first aid. If they want to refer, they can refer, but they must accept, examine the patient, determine the situation. If it's what they can handle, they handle. If it's not, they can refer. But it's not acceptable without touching a patient. From there, you say, no, we don't accept. It's gunshot injury. Take the person away. So it's mandatory that a healthcare provider must see emergencies. That's Section 20 of the National Health Act. If the healthcare provider fails and is convicted, he might get fined, I think 200,000 naira, or 6 months imprisonment, or both. But it's not automatic. Someone has to go to court, and that's where Barrister Ebenezer Guatu, a lawyer who is involved in patient rights and also rights of health workers and stuff, are involved. So if you don't take the matter up, nobody would just go and catch the health worker. So, but that provision is supported by this 5%. The 5% for emergencies, it was more than that before, but in the course of politics of the National Health Act, it was reduced. It's assumed that Nigeria will provide health insurance for emergencies so that they won't be asking for deposits. If I begin to talk that deposits one now is a long story. But good morning, Totla, how are you? Something leads to something. Private hospital is a business, and businesses are rarely run with emotions, okay? But the healthcare is a humanitarian service, in quotes, and there's strong emotional component to it because life is involved. So there's this thin line or some sort of conflict in the private care providers, the business side, because you need to make money. If you don't make money, you won't replace your drugs. You won't be able to pay your health workers. You won't be able to clean the environment. You won't be able to maintain your facilities. You won't be able to buy new facilities to keep caring for people, right? So the monies need to come in so that you keep the place running. So in emergency situations, people do come in out of human empathy. They get treated. Some of them, when they get better, they disappear, especially in the night. And I've had patients like that. You come, you won't find them. They will leave some rickety buckets and a few things, and they disappear. The hospital may have used the drugs and materials worth maybe say 200,000 or over 100 or over 500,000, and such persons will just disappear, right? Even some, their relative will come to them. They will pretend to be good Samaritans. Oh, I don't know them. I just saw this is my neighbor. I just brought them, I will call their people. They will come with money tomorrow. Someone has said they are coming. You resuscitate the patient, it get a bit better. The relative who came pretending to be normal would have disappeared. The patient will also disappear, right? So if a private hospital encounters such 1, 2, 3 times, it will collapse because you won't be able to get enough money to keep the place running. And when the place collapses, everyone suffers. There are people who have money, who want to be treated, okay? So they come because of the bad behavior of some persons that collapse the hospital. Even with their money, there's no hospital to treat them, okay? So, but government hospitals could bear this shock because whether anybody comes or not, they get their salaries. The health workers get their salaries. But private hospitals, if they don't make money, they can't pay salaries. If they can't pay salaries, they lose their staff, and the place shuts down. So in the spirit of this and this understanding, they provided for health insurance for emergencies, so that even the private hospital can treat you. If the person runs away, or it could be covered by health insurance, okay? For that 5% of basic healthcare provision fund. But I must say that 5% is a very small money. Let's say this year's budget, how much is basic healthcare provision fund? I think probably 100 and something billion naira or so, So 5% of that is not up to 20 billion. So imagine the whole of Nigeria. So it's a drop in the ocean. Especially in emergencies. Emergency treatment is expensive, and healthcare is also expensive. If you are getting it cheap, somebody is paying for it. If you are getting it free, somebody is paying for it. There's nowhere in the world that healthcare is cheap. To repair a bicycle is not cheap. If you have pets and you've tried to care for your pets, whether it's dog or cat or whichever one, if you are rearing chicken or pig or any of these livestock, and you have a vet doctor to provide treatment for them, it's not cheap, let alone the human body, okay, that is always busy powering every other thing. So healthcare is not cheap anywhere in the world. So, but for it to be cheap, someone has to pay for it, someone has to subsidize it, and that's where the health insurance comes in. Someone is calling, but I can't. Just a moment, I can't take the call right now. I have to put the other phone on silent. So, coming back to this basic healthcare provision fund, National Health Act was passed in 2014. The fund was not put in the budget for how many years? The first time it was put in the budget was 2018. We had to do another struggle for it to get into the budget of the federal government. The first time it was released was in 2019, So, but right now, every budget is a part of the statutory allocation, that goes into the budget. The release is supposed to be done every quarter, 4 times in a year. At the last count, it's not that regular yet. But let me use Ebonyi State as an example. In 2024, Ebonyi State received over 800 million naira as basic healthcare provision fund. More than 800 million naira in 2 tranches. I think there were 2 releases. So, and Ebonyi has 171 wards. So each of these wards is supposed to has one health facility, primary healthcare facility, that is under the basic healthcare provision fund that should be receiving this fund. Each primary healthcare facility has a bank account. This money is supposed to go directly into that bank account. Then the officer in charge of the health facility is a signatory. The chairman of the Ward Development Committee or Ward Health Committee is also a signatory. So let me take, for example, my immediate community, Okposi. We have 4 political wards. So the Ward 1 is Amechi Primary Health Center. No, Omoka Health Center. Omoka Health Center for Ward 1. Ward 2, Echara Ward, is the Ojigwe Health Center. Ward 3 is the Urban Health Center, Bone Ward. Then Ward 4 is the Ndunu Health Center, right? So those are the ones that are designated for this fund. So if you do calculation, over 800 million by 171, you know what it will come up to. So each of these health centers is supposed to have their needs. When they get this money, they use it to solve their basic needs. It will not solve all their problems, but at least issues around, though there is no light, they have solar power, you know, they fix up certain things. And the communities that these health centers serve through their health committees is supposed to be getting reports, accountability. The village chairman, the Eze or the Igwe or the whoever, the PG, whatever structure at that level, they are supposed to be getting reports. Okay, is it happening? You answer that for yourself. So every ward in Nigeria has at least one health center that is receiving this money. Every quarter or any time it's released. Last 2024, it was released 2 times. My interactions in Ebonyi suggest that they practice, instead of the money going to the health facilities, they use it how they want, based on their needs. They do a needs assessment, they do a budget, they submit what they want to use it for, okay? And they submit to the primary healthcare agency. Based on that, the money will be disbursed to them. But you know what? I reliably gather that many of those things were done centrally. Instead of these health facilities, and sometimes they're even told what to put on the budget at the state level. Not for the health center in my community to say, okay, we don't have the food delivery kits, our delivery couch is bad, we want to get this, you know. So that might be their need, but maybe someone somewhere will be like, oh no, the solar street lights we want to procure for all the health centers in the state, and we deduct it from that money that is going to you, do central procurement and distribute to everybody. So that's not the spirit of the basic healthcare fund. So the spirit of it is there should be independence. Let the community determine what they need. Let the health center with the community, they know what their primary healthcare needs are, what the health facility needs. They might even be doing outreach. Some part of that money could be that, okay, there are people who are living in farm settlements, so let's use this money. Every Eke market day, they gather the people go to Ojigwe, so Ojigwe market, so we can send some health workers to go there and check elderly people, do blood pressure check, do some, sensitize them, you know, using loudspeaker about their health and stuff. So those outreach could be done from the money, and they use that to take care of the logistics for that. They can use it for drug revolving fund, buy essential medicines, okay, so whatever it is. So it's not meant to be used centrally for at the state level people to dictate, but that appears to be what is happening at the moment. And I also heard from one of the OICs, you know, in the state, that is about 300,000 naira that they got. Okay, press your calculator. Over 800 million times 171. Okay, that is 171. So your guess is as good as mine. So the amount they essentially get there to the facility that they manage is very far from the amount that is meant for them. So while we complain that our primary health care is not working, the question is, why is it not working? What is supposed to be done? We may argue that Nigeria is now allocating up to 15% of its budget to health, as agreed by the National Health, by the Abuja Declaration 2001. That's right. But we pushed that for a certain point, and it got to a point that we know, okay, yeah, we are not funding health enough. But the one we are funding, are we getting value for the money? Why are we not getting value for the money? One of the reasons is that you and I are not involved. The citizens, they don't know what is happening. So they just left it for health sector players. It's not a business. People, both those in government, those, there's the ecosystem, especially those in government who manage this money. We as advocates, we just shout, push, 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 push. The civil servants, we don't talk. So when the money comes, it goes into the budget. Who are the ones to manage it? The civil servants. Then things we don't envisage will begin to happen. Okay? So, but who will stop this? And I'm not like giving a bad name to all civil servants. There are fantastic people in the civil service. There are also change makers in the civil service. So everybody is not bad, right? So, but there are certain practices that are happening maybe at the top, and those at the bottom, they don't like it, and there's nothing they could do about it. For example, monies that are generated in primary health care centers are not supposed to be sent anywhere. They should be used within the community, because primary health care center is not a profit-making this thing, but it's expected to generate some money to at least replace the drugs that are being used and take care of a few things. Then with the basic health care fund that goes to one, it's not all the health centers that get this fund. It's one per ward, that gets it. So they use it to sort out some things within their communities. So, but in Ebonyi, they have what they call IGR for primary health centers. So every primary health center has some money that it must send to the local government, and local government will send to the state, to the primary health care agency on a monthly basis. So what's that money used for? Money that's generated. That's why you go to get malaria treatment, they will tell you, they will look at you and say 10,000. They've done it one time. I took my uncle to my primary health center. Then that should be like 6 years ago or 7 years ago. They say 5,000. I say 5,000 for what? There are free malaria drugs in this facility. There's NGOs supporting free malaria testing and treatment as at that time, not now. So why does he need to pay for it? Have you even done tests to confirm if he actually has malaria? And if he actually does, have you offered the oral drugs? And you are going direct to give injections. Why are you giving injections? For someone that is not in coma, for someone that is not vomiting. I asked those questions, they got upset. Are you the one to teach us what we are doing, what we do? We are trained. They didn't know I was one of those that developed the manual used for their training. In Abuja, I was one of those that developed the manual that were used to train them. And they are bragging that they were trained. I shouldn't tell them what to do. Of course, I had to call the state malaria program manager then, and my uncle was treated and he didn't have to pay because those drugs are meant to be free. But you do know why things that are meant to be free are not given free? Because the community is not aware and they feel less concerned. So it gives us, and when I say us, the health workers, especially the bad guys among us, to play God, to use resources that should benefit the people, turn it into personal things, make personal money. You see a community health worker whose salary is maybe 250,000, working in a government-owned health center, and is building a duplex. There's no other business the person is running. So where is that person making money to build duplex? Why are the teachers who are earning similar salary or maybe something less, why are they not building duplexes? So these are things we need to interrogate, but not as individuals, as a community. So does your community have a health committee? I spend a lot of time on this, trying to break it down so that the easiest thing to do is to complain, to point fingers. But the weakest point in our health system in Nigeria at the moment is the non-participation of communities. is the non-existence of functional and effective community health committees. That's the reason why the states might buy equipment and supply to hospitals or health centers, and those equipment will end up in private clinics of some people. Maybe if the people working there have private clinic, they will steal some of them and take there. Some will even steal and sell to private hospitals. You see some that will be written not to be sold, blah, 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 but they get sold and find their way to private. But if the community is involved, anything that is coming in, the community is aware. And if it gets missing, the community will ask questions. If the officer in charge or the health workers don't give satisfactory answer to the community can write a letter to their representatives, their House of Assembly member, or their councillor, or their local government chairman, or even the governor, or the commissioner. The community can write anybody. And when they write as a community, they will get response. The community can summon a meeting at their town hall and summon people to come and answer some questions. If you call a health worker working in the community to come there and he or she refuses, you can write and say, this health worker is sabotaging us. We want this person to be transferred. So the community has so much powers that they are not using. We only use it for burials. Every time we are contributing money to bury people, we don't contribute money to fix problems in our health centers, to prevent preventable deaths, but we've not so normalized certain WhatsApp groups every now and then to bury young people that should live older, bury women who died from complications of childbirth, bury people who should go to hospital to deliver, but they are in one prayer home. They are praying. They have obstructed labor. When they are about to die, they rush them to go and die in the hospital. And we are not holding anybody accountable. And they will say it's the will of God. It's not the will of God for such death to happen. So my appeal this day, 15 June 2025, 5th year of the MakeOurHospitalWork campaign, is for citizens. When we say community is made up of citizens. So let's make this push. 2021-2022, I got support from Talk Health Nigeria, which is an organization I got support from OSIWA, Open Society Initiative for West Africa, to kind of test some of the principles, ideas we are doing through the MakeOurHospitalWork campaign. So we went to some villages in Ebonyi. We also had a radio program supported by the grants. So the radio program was to create awareness, to talk about this thing we are talking now. We don't talk out for radio, especially in Ebonyi. Then I also used Talking Out with Dr. Lars on TV, invited experts that also talked about it. Out of over 100 something shows I did, at least 10% was dedicated on issues around primary health care and making our hospitals to work. So we tested it. Communities were reluctant, but after some time, some of them set up health committees. We say those who set up health committee will come to your village and sensitize them on their responsibilities. We printed the National Health Act, we printed the Basic Healthcare Provision Fund Manual, and we printed the World Health Systems, the policy documents that describes the roles and responsibilities, so that they know that it's not just me talking. This is law, Nigerian law. Okay, so they have powers. Nobody can, intimidate them when they exercise those powers. Because some health workers know grief. Some health workers we report only to our boss, to the administrative secretary or to our oga at the top, They don't feel like they have any responsibility to the community. But when we sensitize the communities, for affected communities, they were able to assert themselves and say, no, you must respond to us. Because the health center belongs to the community. No matter who built it, whether it's the government, federal, state, or individual that built it, when it's a public health facility, the community has control over what happens there. Excuse me, let me take some water. So, and the communities that had health committees, we witnessed some tremendous things that happen. And there are also communities that are working very well with the health workers there, with the nurses or the community health extension or the officer in charge in the health facilities. There are some. So we had like 7 villages in Afikpo, 3 in Ugulangu, 4 in Oposi, So we sensitized them. 2 of the villages, about 2 or 3, their healthcare facility, one of them, Amangbala Health Center, fell, collapsed, very old building, built with mud house. We gave them idea. You can move this, you have a town hall you are building, set part of it and convert it to a health clinic, So it's not just town hall once in a while, it's empty most times. So let people be going there. And they did that. They, redesigned the town hall, used part of it. They raised money. We even had them on radio where they announced their account numbers, So they raised money within the community and moved there. If they didn't do that, because their health center had collapsed, they would have stayed without any health facility. They would be waiting till when they will raise money to start building a fresh one. But they say we have a town hall, so take part of it and use as health facility. And they did that. Ambori Health Center in Afikpo, they had a health center which was somebody's private building given to them over the years. They now they didn't wanted it back. They also did similar thing, went to their town hall, got some rooms to be part of it, raised money locally, wrote letters to their representatives to get that done. Okay, same with Amogudu in Ugulangu. So these ideas were, even though we gave them those ideas, they could do that. And we couldn't have done it for them. They own the place, they have the powers, they have the leverage, they can reach anybody in the community. So those things started taking place. That's community power. So Agba Oziza, also in Afikpo, those ones was that they had a windstorm. I think bushfire burnt part of their health center. And the roof was off, the place was not in use. And they were too scared. They're like, this is government thing, nobody should touch it. They could not even do anything about it. But we told them, if you are waiting for government, you wait forever. People will come and steal the remaining things there. It belongs to you, it belongs to the community. The health committee that you now formed can raise money from your people and fix it. And within 2 months, they raised money from their people, including those in diaspora. And they fixed it. So knowledge. These are things that the communities can do, but they are not doing. And everybody will just lament. When someone gets ill, they die because nothing happens. We contribute money, free food, free drinks, merriments during burials, even for young people. So I can't say this enough, okay? So I spent a lot of time in primary healthcare. I've spent over an hour, but I want to round up within the next 20 minutes so that everything could be like 90 minutes talk. The building blocks of the health system. There are 6 building blocks of the health system. So see a health system as a house that has 6 pillars. So I'll go through each of them and I'll now kind of try to explain. They are all connected. Number 1 is human resource for health, the health workers. Number 2, service delivery, health service delivery, the treatments, health check, diagnosis, surgery, everything we do for you when you go to a health center, is under the health service delivery. Then health management health information system. Health information system speaks to medical records. When you go to a health center, the first thing is card, or a hospital card. If it's a computerized one, the first thing, what's your hospital number, they put it in a computer, is your record. So it's that card, that record you have that makes you a patient of the hospital. So and that record is very important. You exist as record in the hospital system. So and decisions in the managing the hospital and even managing our entire healthcare system is made with records. So if the records are good decisions. If they are bad records, it will be garbage in, garbage out. So That's number 3. Number 4 is access to essential medicines or drugs, vaccines, medical products, vaccines, and essential medicines. Where you go, a woman delivers and there's no oxytocin. It's an essential medicine because after delivery, when the shoulder of the child comes out, you inject it because that's what helps to contract the womb and prevent excessive bleeding. The number 1 cause of death from pregnancy-related issues or childbearing issues in Nigeria is excessive blood loss. So, and the way to prevent that is that oxytocin injection that is given immediately so that it contracts the womb and we don't lose so much blood. So when that thing is not there, the chances that a woman will die after childbirth is high. So it's an essential medicine. So and there are different kinds of essential medicines that must be there in every health facility. So access to them, making sure they are there in the right condition and all of that. Issues that leads to that is also one of the blocks. That's number 4. Number 5 is health financing, and number 6 is leadership and governance. As you can see, of all these, let me go to the human resource for health, service delivery, health management information system, access to medicines, medical products and vaccines, health financing, leadership and governance. How are they linked? I go to a hospital. I walk into, say, a general hospital. First, I'm directed to the medical records to get a card. I've gotten the card. That's health management information system at work. Okay? So I'm asked to wait to see a doctor. While I'm waiting, the nurse has come, checked my blood pressure, my weight, my temperature, my height, those basic things. That's service delivery. The nurse has provided some services there. It now does triage to tell, okay, this is the place you go, this is the consulting room you go to see a doctor. So you go, you see the doctor, the doctor is seeing you. He's also taking records inside a case note or using a tablet. That's also health information system, keeping records. So as he's checking, gives you a prescription to do tests. You go to the lab, your sample is taken, service delivery, right? Your result is given back to the doctor. It makes a diagnosis, prescribe drugs, service delivery. You go to the pharmacy. Are the drugs available? Are they in good condition? Are they expired? That's medical products. So are they in good condition? Are they affordable? The affordability is now health financing. What makes it affordable is either how are you paying for the drugs? How are you paying for the tests you are asked to do? How are you paying for the consultations? Who is paying? Are you paying full? Do you have health insurance that is paying part of it or that is paying 100% of it? That's health financing. So are you paying out of pocket? In Nigeria, over 70% of healthcare expenditure is out of pocket. You just pay everything. If you don't have money, you are stranded. And that's not good enough. So that's why we are pushing for expansion of health insurance. Because the way insurance works, everybody contributes, but it's not everybody that gets sick at the same time. Okay? So, for example, over the past 6 months, my health insurance contribution is over 300K, right? Close to 400K for one life family package for the past 6 months. But the only time my child got ill, had conjunctivitis, the whole draw was around 2.5. Okay, so it's just used 2.5 out of close to 400, and it's expiring this month. Is it lost? No, it's not, because there are people who contributed maybe similar amount and they've gotten treatments close to $1 million. I wouldn't start praying to be sick or for my children to be sick because they have health insurance coverage. Okay, so but anyone could have a health condition that may cost far more than that contribution. So the idea is there's a pool of funds you put out there. In some cases, it might be the government that will contribute, especially for elderly people, for children under 5 years. Some, it might be your employer that will provide the health insurance, So, but having health insurance is very critical. And in almost every state now, you can even buy for yourself if your employer is not providing for you. So that when you have health need, you don't start begging for money. There are people I know can afford health insurance, and when they don't have it and they have big health challenges, start begging for money. I personally don't feel obliged to contribute to such funds. I feel that they are not responsible enough because they know about health insurance and they feel it doesn't matter. So when they need money, they might have to sell their property, to take care of their health. So because we preach these things, we talk about it free of charge, people are not interested. They're only interested that, give them money when they are in need, So health financing. So you could see from the human resource, the health workers themselves, to the service delivery, to the record, to the medicine, to the financing. Then where does leadership and governance come in? Leadership and governance is at different levels, which I talked about at the beginning. The governance in government, governance in communities. Every community should have a health committee. The patron of the health committee is the Igwe and the PG, or the chairman of the village, if it's a village level, they're like the patron. And the health committee reports to the village. If they are doing annual meeting, community meeting, the health committee should come and give reports using data that is provided by their health facility. If they have one, it's not every village that have health center, but that doesn't mean they shouldn't have health committee. If it's a village that doesn't have health center, it's not every village that needs to have health center. It's not every health center that is viable. If you have a population of 150 people in one small area, why will you be building a health center just because you want your village to be said to have a health center? Health facilities are very expensive to run. The cheapest part of a hospital or a health center is the building. Many people set up committee after building, dancing and cutting tapes. They feel like, we now have a health center. What we have is building. If you don't have other components, which the building is just infrastructure for service delivery. So it doesn't take care of the health financing. It doesn't take care of human resource. If you tell them to hire people, they say they don't have money. They give it to government. Government will not hire people many of the times. But if we start pushing government through our health committees, and they start seeing that this is not just the health workers or the health advocates disturbing us, it's the people that are demanding this. Anything you start disturbing government, they start doing it. So when we have health committees, and the health committee hire 1 or 2 persons, pay them for 1 or 2 years for their health center, and they can't carry it again, and politicians come to do campaign, and you tell them, when you get there, are you going to hire health workers for us? We've been hiring and paying, we are tired. Take over from us. They begin over time. Instead of sharing keke to people who may not need it, or doing some other sponsoring football competitions, which are all good anyway, you don't have to prioritize to be like, okay, instead of 200 keke, let's share 100 keke and use the money for 100 as constituency project for those that do that, and support this community to pay their health workers in the next 3 years, pending when the state government will now do mass hiring. Have you wondered why governments rarely want to hire people? This one will come, new buildings, they will cut ribbons, we celebrate. And that one, we'll be asking them, how many hospitals did you build? No, we should stop asking how many did they build. We should begin to ask how many have they got functional. We have many hospitals that are not comatose, and new buildings will not solve anything. After building, they will still go abroad for treatment. After calling it ultra-modern, state-of-the-art hospital, we are now stopping medical tourism. Everybody will be coming to Ebonyi, for example, best hospital in Africa. Yet, you have a medical emergency, they will move people from the community that has the best hospital and start moving them to 1 or 2 hours distance to get healthcare. So we need to get serious about this thing. Slump and die is a common phenomenon now. Rich, poor, anybody you just hear of slump. The economy is too tough. There's so much pressure in the world. Everywhere. People are struggling. The countries you think they are comfortable, they are now saying people should stop coming. You are coming to take our jobs. We don't need you again. It's economics that is causing these things. They are in lack. If there is so much abundance and there's job everywhere, they wouldn't care. So they're also feeling some economic brunt, and they now started seeing immigrants. Oh, if these people don't come, we have enough for ourselves. And it does happen everywhere. So nations bombing, wars all over the place, insecurity, so much pressure all over the place. Internal, external. So, and with this, so much stress, it produces a lot of hormones, and if care is not taken, the body will just shut down. And so someone has slumped. And that's why making our hospitals work is, I will use the word hospitals, doesn't mean it must be big hospitals. I emphasize today on primary health care. I didn't go much into teaching hospitals and general hospitals. So when we get the primary health care right, there will be less pressure on the teaching hospitals. If you go to some teaching hospitals in the country, to be like markets. People, cough and catarrh is there. I didn't sleep well is there. My eyes are red. Every basic thing that can be taken care of in our health center is going direct to teaching hospital. And that's why you have everybody. And those who have kidney failure, heart failure, burns, severe burns, fractures and very serious conditions that needs full attention. Teaching hospital is not a place you have crowd of patients. You can have one patient that will take, you just have the time of the health workers for almost a whole day, just paying attention to one patient because of the condition that person has. It makes a whole lot of difference in whether the person will survive or not. There are people who are to be on drugs every 1 hour. There are people who you have to monitor every 30 minutes. Even when they have machine monitors, there is still need for a human being to check the reading of those monitors to know whether to adjust or not. People who require intensive care, there are health workers who need to be on standby. They don't need to be too busy. Somebody needs attention, they are called upon, they move. And that movement could be what will determine whether the person will live or not. Okay? So, at the teaching hospital is where this tertiary care is meant to be given for very serious health conditions. Not someone that has been normal delivery, you just start going to teaching hospital. No. It's for complicated, someone will be referred. Or maybe problematic pregnancy. Someone that has sickle cell in pregnancy, hypertension in pregnancy, some of these special conditions that the delivery is planned, everything is put. If there is need to enter theater, before the person starts pushing, the theater is ready. So if you see a signal, say, okay, we move, get in there, bring out the baby, mother and baby, everybody fine, and everybody is on standby. But when you have such persons so busy attending to very flimsy things that could be taken care of, nobody will get good quality. It's not about them being wicked. They are human beings too. Our health workers are overworked. I want to close with some numbers in the Human Resource for Health, which draws to the dangers that we are. In March this year, there was a release that only 825 medical doctors signed for primaries. Primaries exam is those who are already doctors, they finish with service, they are medical officers, they want to become specialists. Okay, so in the whole of Nigeria, there are 825 people. Before, we used to have more than 8,000 people writing this exam. And they will be competing, going to different hospitals, teaching hospitals to start residency. But now, we could not even get up to 1,000. Without specialists, who will run our teaching hospitals in the near future, when people are not interested in specializing in Nigeria again? What it means is the current consultants and specialists that we have, when they are retiring or getting old or some dying, or we will not have people to replace them with. And in 5-year periods, in 2024, the Medical and Dental Consultants Association of Nigeria said that about 1,106 of their members left the country. These are specialists who left Nigeria between 2020 and 2024 to other countries, and more are still living. So while the existing ones we have are living, the medical graduates we are having are not interested in becoming specialists in this country. They are also living. Okay, so we'll get to a point. We have about 49 medical schools in Nigeria now, 41 with full accreditation and about 8 with partial accreditation, right? So you need consultants or specialists. They are the ones that are qualified to train doctors or or dentists from 400 level up. You need from 1 to 300 level. You may have anatomists, physiologists, non-medical doctors predominantly involved, but from 4th year is predominantly medical doctors and consultants who can train. So a medical school that doesn't have the right number for these people will not have accreditation. So apart from the impact it's having on care, that we will not have enough specialists to care for us, it also means there is a danger to the survival of our medical schools. If they are not in their right numbers, medical schools will begin to lose accreditation, or will begin to lower standards in order to accommodate what we have. And when that happens, it's a danger to all of us. So it will get to a point that some medical procedures you used to do in this country, now the problem is whether you have money to do it or not, or you go to a private place and do it. A time is coming where you have the money and it's not even a complicated procedure, but you will not find who will do it here. Or you find someone that will do it, you go in June, they will tell you the next available space is September. Can you wait? Longer waiting time. Even when you have your money, you move around, no space anywhere. It's already happening. It's already happening, and it could get worse. Okay, so doctor-patient ratio by World Health Organization, the standard is 1 doctor to 600 persons in the population. Nigeria, over 200 million people, right? So if we have 1 doctor to 600, it means we need more than 300,000 doctors, okay, for Nigeria. We need more than 300,000 doctors. So how many do we have? So instead of 1 to 600 persons per population, we have about 1 doctor to over 9,000 persons. Okay, So in response to this, the federal government of Nigeria now increased the quota doubled the quota for training of men, because they were producing about 3,000 doctors per year. They now doubled the quota. So schools that have accreditation to produce 150 people now have to admit up to 300. Those that have accreditation to admit 100 people now double. They can admit 200. Well, why that in a way may bring a bit of support, but it doesn't substantially solve the problem. Because if you used to produce 3,000 before, maybe 1,000 leave and 2,000 stays, and you don't solve the problem of why they are leaving, and you now produce 6,000 and 5,000 leaves, and you have 1,000 staying. Even though you are producing more, if more leaves, you've not really solved the problem. You've only succeeded in producing doctors for other countries of the world that are more serious about their health system. So in solving this, we need to begin to pamper our health workers. And I may sound biased, I'm a health worker myself. If you go home, those people that are working in the communities, what do you need? What challenge do you have? Why we look out for those who are doing wayo, so to hold them accountable, those who should be, we say, they are not at their duty posts. If you have a health center that should have at any time 8 health workers working. You know, this one run day shift, the other one run night shift, but you only have 2 to work for 24 hours. How feasible? They will attend marriage now and chop free food. They will attend burials, they will go to church, they will do school runs, they will go to markets. So if you expect them to be in the health facility 24/7, what time will they use to do other things? So it's not, it's not entirely their fault, because it's not possible for 2 staff to be in a health center and you always see them when you go there, even if you have residential building there. And when they cut off from the society, we'll still turn around and be, are you the only doctor? Are you the only nurse? When people invite them to something, they don't attend. So the society does not even give you any preferential treatments for being a health worker. If you go to fuel queue and they say, let's sell to this one because it's a nurse, you need to go by, not only I'm a nurse, you need to see patients. I also have my customers waiting for me. So the person will queue, and when the person queues and that person has an emergency, goes to the health center, the person that is supposed to care for him or her is queuing up in a filling station. So these are things that we need to look at substantially. In 2 years ago, a house officer slumped and died in Lutz, a medical doctor, after being at work for 72 straight hours, non-stop. He just slumped and died. So a doctor that is supposed to see, and I'm just using doctor, is also the same for everybody. Nurses, the standard for a nurse is one, like in a teaching hospital, is 1 nurse for 4 beds. So if you have a 32-bedded general hospital, for example, you're supposed to have 8 nurses on duty. How many do you have? You have a 32-bed ward, and you just have 2 nurses. This one is to have drug, injection. This one is to have wound dressing. This one is to have oral distance. This one is to be turned with powder so that we'll have bed sores. They will share 16. So, and because there are too many patients, somebody that is supposed to take their drug by 1 p.m. will now end up taking the drug by 1 or 2 p.m. because you don't have enough hands. Before it gets to the person's turn for the nurse to give the drug, it will be 2 p.m. Then you come and say, why are you giving this drug that's supposed to be 1 by 2? You people who don't know what you're doing, you're not doing it. And if it's given by 2 p.m., it will not be the same effect, because the drugs have timing. For it to work optimally, you have to follow those things strictly. So if 2 persons are doing the job of 8 persons, they cannot kill. No, even if they kill themselves, those people they are caring for cannot get the quality they deserve. And most times when things work in the health sector, it's a thankless job. When things work so well, when people go to the hospital, they buy yam, goat, everything, go to the church or mosque and give thanksgiving to their spiritual leader. Fine and good. I'm not saying nobody should give thanksgiving. But when it doesn't work, they blame the hospital and the health worker. I don't know what they are doing. They take the blame when it doesn't work. They wouldn't blame the prophet that have prophesied that the person will be healed, and he didn't get healed. But when the person gets healed, the prophet takes all the glory. They will take your number as a health worker. The first time they will call you is when the person is sick. Maybe 3 years after, you've even forgotten the person. Doc, is that your patient? Yeah, my baby's doctor. We came in 2021. Your baby is running temperature. But don't even invite me for child dedication or birthday party. That's how I can remember me that way they run temperature. So in summary, our health sector is in deep crisis, just as every other aspect of our economy. And it's not people, it's also because they don't have enough. When they had enough, they don't care whether their doctors trained here or not. So it's a global crisis. But some countries who are more serious are giving incentives, opening their doors and say, come. They are training more. Okay, yeah. So I think I had poor connection, and it's also a signal to kind of end it. So this we started one. This is 2:37. Okay, we've exceeded the 90 minutes. So there's a whole lot. Take home messages. What can we do? We are all leaders. We are citizens. So your community, does it have a health committee? That's the starting point. If they don't have, please begin to push for them to have health committee. I can share a video. If you go to Talk Health Niger YouTube page, you can see one of the videos where we explained, if you call me personally, I'll charge you consultancy. But I have a video that I can share where we discuss this. Not just one video, multiple videos. The guide or even the documents that can help your community to get started. So have a health committee. You can have 5 persons, you can have 10 persons. There's a composition of the health committee, but it must not be health workers, it must not be health experts, just people who are interested in community service. So they are not going to be treating people, they don't need to be health, it's just community service. So they'll be sensitized and they'll know what to do, and they will participate, supporting your communities to take steps to making primary health care work, ensuring that people get care at the appropriate time. So let the focus be on getting the existing health facilities. Most of our health facilities are not functioning up to the capacity they are made for. The general hospital in my community, the functionality is not even up to what a primary health center should be functioning. And some of the so-called teaching hospitals are not even functioning up to the capacity of a general hospital. But we have to start from the bottom. When it's functioning at the primary care level, it will decongest the tertiary care. We will not have so much crowd there. And the people there, the numbers we have in the teaching hospitals most times are okay. It's just that the people who are going there are outnumbering them, and they are working working their ass out. So we need to get primary health care and general hospitals, secondary health care functional, so that it will decongest the teaching hospitals and will have sufficient time for caring for those who need more of those times, who have more serious conditions, and also for providing quality teaching to the medical students and the dental students, the nursing students, the various health science students, quality teaching, quality research, and quality care for patients at the tertiary level. That will not be possible if the primary care is not working. And primary care cannot work if the community is not involved, because the design of primary health care is community participation, and that's what has been missing, community participation. No matter what the government does, no matter what they supply, no matter how many people they hire, if the community is not involved to hold those people accountable and to also play their own parts in supporting those people, not when one roof is removed, instead of somebody just coming, the community calling somebody within less than 5,000 is fixed, everybody waits until the entire thing is off and the hospital will close, or the health center. So we need to do that to make our hospital work. So that's my appeal, my citizen appeal. That's the big announcement. I'm pushing that in my community. It's tough. I've made presentation a number of times. I've talked directly with leadership at different levels. I've both written, both one of the most difficult. Everybody just come and do medical outreach. So medical outreach is, with due respect, rubbish. It's waste of resources. Those monies you use, I feel many of the medical outreach we do, not all of them is rubbish anyway, but many of the ones we do can be more effective if better designed and done with the community. We plan it with the community, do it with the community, do it in a health center. Those that will be followed up. It's not every condition that you can treat on the spot. There are some you identify, you follow up with further investigations and diagnosis before you treat. So but it's only when you work with the community that you say, okay, this 80-year-old man, this 52-year-old woman, these ones, we need to follow them up. Please ensure that you tell their families, you give them an appointment, they will go and stuff. Those follow-ups are necessary. Many people are fine. They just go to collect free drugs, which they will use when they need it, right? It's fine. You take pictures, people will comment you on social media, right? Fantastic. It's better than doing nothing. But we can get more value for money, when we have a better organized health system, working with communities. If we spend 100 million on medical outreach the way we do it currently, maybe we can get 10% utility. If we do it differently, we can get maybe 70% utility with the same amount. So these are some recommendations that we do make. A lot of persons don't quite understand it, and they are more interested in the paparazzi of the medical outreach and the cameras all over the place, So, and the praises they get. I did medical outreach in my personal capacity in 2014, I think about 3 times. At some point, things I saw a woman who had high BP. That was what actually changed my perception, and I stopped doing that. Had high BP. I counseled them, but she didn't know. Counseled them, gave my business cards. Please call your people. When they come back, they need to take you to hospital. You need to follow up. It's this kind of condition that you just hear somebody slumped. If you quarreled with somebody, they say it's the person that killed him or her. So, and later that year, that woman slumped and died. And I felt like my medical outreach couldn't stop her from dying. So what's the essence in the first place? So because I communicated, gave my card, and they did nothing, right? So, but if there is a community component, for those kind of person, even talk to community leaders, they will prevail on them. When their children come back, they will remind them and say, doing these are the things the health experts say, though. They will make sure that, because the woman should be probably in her 60s or so, or 70s. So they will make sure that those things are followed. But if we just do, and people who are okay, collect drugs and say thank you and go, then the ones they do in my community, I think there's surgical component, which is good. They take some patients, go to the general hospital and do surgery. It's minor surgeries, so that one is excellent. So as you can see, there's connect between the outreach and the health facility. So that is the Christian group that does that and is organized. But they see an aspect of it that, if we have health committees and those health committees are collaborating with them, it will be, the community component will be much more effective, So there's just so much that the people working as volunteers, if they need to be paid, the community will decide, okay, members of this committee will be paying them stipend. It's not to depend on one foreign NGO. NGO can bring money based on grants. Everything will be working, they'll be paying transport, and when the money finishes, they vamoose. And you see people, if you call them for a meeting, they will walk 5 kilometers to attend the wedding or burial. Nobody will pay them. But if you call them for a meeting to walk 200 meters to attend the meeting on how to make their health center work, they will ask for transport. So we need to reevaluate recheck the value system and what we really make to count in our community. So I thank everybody that joined this and stayed from beginning to end. I know some persons may have dropped. I don't know if there might be questions or anything. I'm not so conversant with taking live questions during a live broadcast, So, but whatever it is, you could drop those questions in my messenger. I could respond to as many I can. If there are those I need to do a video to address, I'll do that video. But I really thank all of you that is able to join. And if you're a member of the Make Our House to Work campaign, we have a protocol. The campaign is citizen-led, community-based. So start doing something in your community. Use the manual we've already produced and start implementing in your community. It's a voluntary work and it's for to just help our system. So thanks Gideon, thanks Ebenezer, Emmanuel Okpai, Henry Akujobi, Noble, happy birthday Noble, Dab, the law not be politics, so yes, so everyone, Chidemma Wachuko, Basi, Alex, Ike, Kaji Sly, Ransi Chidebe, all the guy in our project Pink Blue, Osita, a guy in Michael Opera, Barrister Ekibo, I greet you. Dr. Gochukeze Rex, the ophthalmologist. Well done, sir. My sister-in-law, Ifi. Big brother, Barrister Mekeze, happy Father's Day. Now, he trained me for medical school. You say you no train me, you no go get the Dr. Laz when I get today. Thank you, bro. Chris says, my beloved brother, thank you. Enoch. Igweze Chikodre, journalist Paul Oka, we get interest for health. He's also a member of the campaign and he uses media to draw lots of attention. Nemeka Anyene, all the way from UK. Rotarian Henry, that is smart to know. People join this thing well. Demba and Kembo, my own brother, Prince. Dr. Magashi, our guy for public health. Aminu Magashi Foundation. Thanks for joining. Thanks for all you do across the country. Blessing, Lady B, OGB, Aniwachuka, thank you. Okamota, Brian Ezon, Unekana Ayo, Emmanuel Nguta. Chinwoku Okereke, MedLab scientist, Ngene, God's plan. Wow. If I didn't mention you, please bear with me. Thank you very much. Have a very pleasant day. So let's do all we can to make our store work for everyone, everywhere in Nigeria. Thank you, my PG, Barrister Philip Udes, and my other brother. Thank you so much. All my family members who join, thank you. There's no me without my family, so thank you for joining. Well, by Facebook rules now, this video I think may last maximum of 30 days. Before, you may have the option of no deleting. So, but people who didn't join live may still be able to watch it again, and I'll see if I can